So with this, I finish this part of the lecture, my first lecture. I'm going to go and move right away to the second one. One of the important things when we do carotid artery stenting, of course, is the protection device that we use. But the other important issue is the type of stent that we use. My disclosures again, and again, the risk, embolization, macro or microembolization, and the time that we see the complications of carotid artery stenting are in different phases of the procedure. During catheterization, manipulation of the catheter at the level of the aortic arch, as I mentioned before, when we cross the lesion with the cerebral protection device, and then when we do pre-dilation, when we deploy the stent, when we do post-dilation. And then we have what we call phase 4, which is the first 24 hours after the procedure, and then the phase 5, which goes from 24 hours to 30 days. 40% of major strokes occur during phase 1. So when we are trying to put the device in place, that's why cervical protection by direct access of the common carotid artery can get rid of those in many occasions. 60% of the remaining major strokes occur during phase 3. But then we have minor strokes that occur frequently in phase 4 and 5. So that's why we think that the type of stent that we use can be important to prevent some of these problems. Let me show you a case. This is a symptomatic patient with a high-grade stenosis of the left common carotid artery. This is post-endarterectomy. The laser doesn't work well. We need to look for another laser if possible. And this is the angiogram pre. You see a high-grade stenosis before the bifurcation. And we did IVUS, showing a significant lesion there. And this is the pre and post, side by side. You see on the left pre, post, after stenting placement. And look at the IVUS. The IVUS shows at 6 o'clock on the left and also on the right the presence of something inside the lumen that is going through the struts of the stent. So the plaque is not totally contained by the stent, it's not totally pushed by the stent. Part of the plaque is going through the struts into the lumen. And because of that, that plaque can become loose and go to the brain and produce a stroke. So that's why we believe that this type of technology can be improved. This is what's going on. You see here in this cartoon, or in this picture actually, that was from an early study also done by Frank in New York, the particles protruding through the struts of the stent. And what that happened when you have embolization of microparticles, you have what this patient had. She had a TIA and she had silent infarct. You see those white dots? Those are areas of the brain with infarct. So small that they don't produce something that can be detected in a neurological examination. But we don't know what's going to happen with those particles in the long term. Maybe these patients can get dementia or impairment of some functions. So we still don't know, but we don't want to have those things. So what's the problem with the stents again? We have, besides IVUS, now we have OCT, which is even better technology to see the inside of the vessels. Look the definition that we have of the stents, the struts, and you see also in this particular case that was given to me by Dr. Max Amor from France, and you can see the plaque up there protruding through the struts of the stent. And so if you see the armamentarium of things that we had filters, we have proximal protection, we had what we call open cells, closed cells, stents, and now we have cervical protection, and now we have something new, which is the new generation of stents. Historically, we started to do carotid artery stenting using balloon expandable stents. Then we immediately changed because we knew and we learned that those stents got crushed very easily, so we went to move to self-expandable stent, and we were using braided mesh like the wall stent. We also stopped using that one for most of the cases. That stent is still available, but it's not used as frequently as it was before, and we went to the nitinol stents, self-expandable, and you have a closed cell, you have an open cell, and then we had a generation that was called hybrid because it was a combination of open and closed cell. The question is, what's coming next? And what's coming next is this new generation of stents that have at the same time some of the benefits of an open cell stent because they are very flexible, they adapt very well to the wall of the vessel, but they have a second layer to protect for protrusion of plaque. So they have this mesh behind, and we have nowadays 3 stents available. In the United States, only the Gore carotid stent is available during a trial. In Europe, they are using 2 other ones, the Terumo and the Inspire MD stents as well. So let's review each of them. The Gore carotid stent is a stent frame with a stent lattice, and this is how it looks. You see the stent, it's open cell, very flexible, and then you have this PTFE mesh or lattice, which are 500 microns that will protect the patient from having plaque protrusion. And all this is covered with CBAS, which is a coating of heparin that prevents thrombus formation on the surface of this stent. Again, the stent itself is open cell, it conforms well to the native anatomy, and the lattice, it brings high degree of plaque scaffolding that reduce plaque prolapse or plaque protrusion. And this coated all these elements with heparin, which has no systemic anticoagulant effects, provide protection for acute occlusion of the stent. And when we look at the size of the struts now, and we compare with the other stents that we have been using so far, you see that the Gore has the smaller strut size. So in case something goes through that, it's going to be smaller than what can go through the other stents. Delivery system is very slick, very flexible, and the deployment is very precise. There are different sizes, including taper devices configuration, like we usually use, because we want to bridge from the internal carotid artery to the common carotid artery. And again, as I mentioned before, we are using this stent at this point under a trial, which is the scaffold trial, which combines the use of the Gore carotid filter with this Gore carotid stent. It's a multi-center trial in the United States, single arm. And of course, we're trying to evaluate the safety and efficiency of this technology. The primary endpoint, similar to the rest of this type of studies, death, any stroke, and myocardial infarction. And the first case was done here at the Medical University of South Carolina back in August 2013. He was a 77-year-old patient that had contralateral internal carotid artery occlusion and had a high-grade stenosis on this side. As you can see, occlusion of the left side, occlusion there of the left side internal carotid artery, high grade on the right, and you see the angiogram before and during the procedure, and the final angiogram after that. We've been following this patient, and he did very well until very recently, where he expired due to his pulmonary fibrosis. But the follow-up ultrasound showed that the stent was doing very well in terms of patency and no recurrent stenosis. If you want more details, we have published this first in man case in the Journal of Endovascular Therapy. And we have included some other cases, as this one you can see here, a 76-year-old patient, symptomatic, with a bovine arch, high-grade left internal carotid artery. This is before. Again, it's a symptomatic patient. Images before, during, and after, showing good angiographic result and good clinical result. This is another patient with a high-grade lesion after carotid endarterectomy, before and after. Another one before and after, and even this one that was a high-grade stenosis. As you can see here, no flow to the external, very, very narrow internal carotid artery, also a recurrence on a patient with extensive cervical surgery due to cancer after treatment using the filter and the carotid stent. So these are the centers that enrolled the first 100 patients. And after we finished those 100 patients, the data was sent to the FDA, and now the FDA gave the green light to continue with this study, and we started to enroll cases again 2 weeks ago. So we are now in a condition that we can include cases here at MUSC as well. And there are 220 more cases to do to complete the trial before we can submit the final information to the FDA and hope that they will approve this technology. So in conclusion, for this part, embolization can occur during stent post-dilation, what we call cheese grater effect. Embolization occurs after protection devices are removed due to plaque protrusion through the stent struts, and this type of stent, this type of technology can prevent problems, those type of problems. Couple of slides to show you what's going on with the Terumo Road Saver device. It also has 2 layers. As you can see here, a closed cell structure with flexible nitinol weave, dual layer micro mesh design for sustained embolic prevention and high plaque coverage. Is retrievable and repositionable on a 5 French delivery system. This is really interesting, because if you don't like where it is, you can remove it. And when you see how this stent compares with the other technology, you see that it's really a very small size of struts. And this is what people are expecting. You see one of the stents that we usually use where there is plaque protrusion, and the idea is that with this type of stents we will have good apposition of the plaque with no protrusion of the plaque through the stents. And then, just to finish, the last thank you. The last stent that is available with this type of technology, the CGuard. As you can see here, the mesh is even smaller, to the point that, you know, if you think that you can eventually occlude the external carotid artery and you can jeopardize the flow, you can go through the mesh and balloon dilate that to increase the size of that exit to maintain flow in the external carotid artery. They have done a trial in Europe, the CARINET 1 trial, and these are the results, 0 everywhere. This is really encouraging. And not only no strokes, no death, but also the presence of new lesions has been shown to be reduced significantly by the use of this technology. And these are images, IVUS images of the cases that were included in the trial. So in conclusion, also this stent provides good protection. The success was 100%, and compared to published diffusion-weighted MRI data of non-covered carotid stents, the incidence of new ischemic lesions was reduced by almost 50%, and the average lesions volume per patient 10 times smaller. So now that we see, I show you these three technologies. If we compare the size of the struts, you see the closed cell stents have at least 1,050 microns. The Gore has 500, the Terumo has 375, and the CGuard has 165. So the question now is, if we have a great stent, like these three that I just shared with you, and apparently we have this advantage of doing the cases with flow reversal at the cervical level, what if we combine these two things? Maybe the combination of two things can provide even a better result, because each of these technologies are focusing in reducing the incidence of stroke and complications in different aspects, different ways. So maybe by combining both, we will get an ideal result. Thank you very much for your attention, and I'm open to questions that I think we're going to do at the end. So thank you very much.